Greetings from eMedi News, Heartcare Foundation of India and Board of Medical Education, Mulchand MedCity. Welcome to our show, Chat with Dr. KK. We have with us Dr. Rohit Aggarwal, who is Assistant Professor of Medicine and Medical Director, Arthritis and Autoimmunity Center, University of Pittsburgh, USA. Welcome to our show.
Thank you.
Inflammatory spondyloarthritis, confusing subject for a physician. Yes. Most of the time they miss, ends up into with a quack and ends up into steroids. And we have seen a lot of patients diagnosed with ankylosing spondylitis at the age 40, 45, 50, never treated, and by the time they come, they are absolutely in a gone case. And when you send it to a rheumatologist, they say, sorry, you have come late. Now I can't do anything with that. Yes. So, A, what is inflammatory spondyloarthritis, and why do we need to separate it with inflammatory polyarthritis?
Okay. So, inflammatory spondyloarthropathies is predominantly inflammatory arthritis involving spine as this prototype joint, as compared to polyarthritis, which involves small joints, peripheral joint as a prototype. The part of the problem is that it fuses the spine. It can be ankylosing. So it's actually very debilitating if you miss it early on. And often these patients, you would say, they would have lower back pain when they are young. They either ignored it or their doctor ignored it. There's generally some, so I would like to give you some clues of lower back pain. When a young patient comes to you with lower back pain, how to differentiate between a regular garden variety lower back pain, which is this disease, as compared to inflammatory arthritis, inflammatory spondyloarthritis. So generally, if a patient comes to you and say, I have lower back pain, which is worse early in the morning, or later part of the night, I have to get up from the bed and move around and come back, or early morning is the worst time. That's one of the feature of inflammatory lower back pain.
And again, it will improve with walking.
Improve with activity. Improve with activity.
That's a sign of immunoinflammation.
Yeah. Worsening with rest. Buttock pain at night. And then
is
also,
there any link with the ankle joint or the heel pain?
Yeah, I was going to come to that. So but those are the features of inflammatory lower back pain. Along with that, if you have other features also, for example, plantar fasciitis, so heel pain, or ankle Achilles tendonitis. So the seronegative spondyloarthropathy causes a lot of enthesopathy. So these are all the sites where the tendon inserts on the bone is where the enthesis lives, and that's where the plantar fasciitis happens. That's where Achilles tendonitis, patellar tendonitis, costochondritis and difficulty in taking deep breath are all the other features of seronegative spondyloarthropathy. But the back, identifying a inflammatory lower back pain in a young patient is the key.
Can the plantar fasciitis precede spinal?
It can. Often it can.
So you can have a year before.
Yeah. Often if you ask the history, they will say, yeah, I had plantar fasciitis a year ago, which got better.
Which got better. So, okay, now we are suspecting inflammatory spondyloarthritis, and the patient has a back pain, he improves with walking. Now, I have options with me. One option is HLA-B27, second option is ESR and CRP, third is sacroiliitis to look for X-ray or a CT scan. What do I do further?
ESR and CRP has not much role in seronegatives. So I would not worry about that, but I would definitely get HLA-B27. I would get bilateral sacroiliac joint X-rays to look for early sacroiliitis. And then also on my exam, if I'm finding sacroiliac inflammation, that's also a key towards it. So those are the initial investigation I would do. Now let's say your X-ray is normal and HLA-B27 is negative. That doesn't rule out seronegative spondyloarthropathy. It just makes your job difficult, because you didn't find the markers. So oftentimes I see physicians saying, oh, your HLA-B27 is normal and your X-ray is normal, and so you don't have seronegative spondyloarthropathy. That I think is completely wrong. You have to go by the symptom and exam, which is the key in these diseases. Now you have to think about what are the possibilities of seronegative spondyloarthropathies. You have to ask for rash, psoriasis, if the patient has psoriasis. If the patient has family history of psoriasis, may not have psoriasis themselves, but if a family history of psoriasis or a family history of ankylosing spondylitis or inflammatory lower back pain, that increases your suspicion. If they have a history of enthesitis, plantar fasciitis, patellar tendon issues, that again increases the suspicion.
What about inflammatory bowel disease?
Bowel disease,
they can also present with the
completely similar features. Then you can have reactive arthritis also. The patient had UTI or URI some time ago, and now they have developed into more of a reactive arthritis. So the clinical history, unlike rheumatoid where you have CCP and rheumatoid factor in to help you in 85% of the cases, here the clinical history is more important. So it's actually that's why it gets missed more than rheumatoid arthritis, because the testing, blood testing or X-ray testing are not that great. Now, if the X-ray is normal, your first thing to do is MRI of sacroiliac joint, because that has a very high sensitivity and significant specificity for diagnosing sacroiliitis. So if you have a young patient with clinical history like this, with bilateral sacroiliitis on MRI, that's your diagnosis. You're done.
So now I have a patient confirmed there is a bilateral sacroiliitis, HLA-B27 positive or negative. Let's say it's positive.
Right.
So this is a classical diagnosis of inflammatory spondyloarthritis. Now I want to start treatment, and now we have been told, if I am correct, that NSAIDs works like DMRD. Disease modifying drugs in patients with ankylosing spondylitis. That means you give them
full dose NSAID.
Full dose NSAID for 3 years.
Full dose regular dosed NSAID. So not as needed, not SOS. Full dose regular NSAID. So either you give naproxen 500 milligram twice a day, or you give them indocin 3 times a day.
For how long? For 3 years?
You have to continue for long term. So it's a disease modifying.
So NSAID is a disease modifying in inflammatory spondyloarthritis.
Yes.
Okay.
But
no steroid.
No steroid.
So only NSAID, try them NSAID, and that means at any stage I can start, or do I?
You can start at any stage, because
even if it is a burnt out disease?
If it's burnt out disease, if it's not made any improvement, we don't continue. So you can start to see if it improves, but if it's, let's say 3 months back, so you give course of first 3 months, and even 3 months they say, nothing has happened, no inflammation changes, no morning stiffness improvement, no tenderness improvement, then you stop it or you change the drug.
So I start with NSAID full dose in a patient with when I suspecting inflammatory spondyloarthritis, cover them for GI bleed and other things. And is there any role of calcium, the drug which we give, zoledronic acid or other things?
There is, if you look at the literature, there is no role of zoledronic acid, proven role of zoledronic acid.
Or similar drug, palmindronic acid?
There's no proven role. Now, I know physicians in India do give it. They haven't really published their findings, so I'm not sure how much does that work. But there is no proven role of those drugs right now.
So at the moment, if you get the patient, give them a full dose of steroids, the full dose of NSAID, and if the NSAID fails, refer.
Right.
So that they can go for biologics.
Biologics.
Apart from biologics and NSAID, there is no other treatment.
There's right now no other treatment. Now, if you have a patient with, along with seronegative spondyloarthropathy, they also have peripheral arthritis, then the role of methotrexate and sulfasalazine comes into the play. So I would often try them sulfasalazine and methotrexate if they have involvement of peripheral arthritis, because that will overall improve.
How many percentage of cases with spinal arthritis will have a
about 30%.
30% of them. So that means if a young patient comes to you with a peripheral arthritis with a spinal involvement, seronegative, anti-CCP negative, unless proved otherwise, is spondyloarthritis. Right. And they have to be treated like a mix. And NSAID along with like a treatment of a polyarthritis.
Yes.
That's the mixed treatment with that. So what we have learned today is that inflammatory spondyloarthritis has to be differentiated from inflammatory polyarthritis. It's common, and if you don't diagnose them early, it will end up into a bamboo spine, which will be a lifelong limitation for a person to live. And remember, when we talk about disease modifying drugs, in rheumatoid we have a group of drugs, but as far as inflammatory spondyloarthritis is concerned, painkillers, the NSAIDs in full dose works like a disease modifying drugs, and if they fail, you have no option than to refer them for biologics. That's all for today. Let's thank Rohit to be in our show. We'll come back with one more show. Till that, goodbye. Thank you.